hand and shoulder surgeons, and shoulder covers from here to the elbow and hand covers here to the elbow, so they kind of cross over. Is it like surgical or is it
No,
not
it's
surgical?
probably just, they do like cortisone shots.
Okay, yeah, I think, yes, I think we do it. Normally it would be like, Muskie,
The guy who's doing.
Madsen, yeah, those two, or, that's fine. Lou Gobson, he's our shoulder doc. He would also.
Okay, okay, thanks.
They shoulder and elbow.
Actually, I said yes, but you would have to like
I'll go with
call and find out because
He's more
it's
sensitive.
tricky. Well, no, he's surgical, he'll do shoulder. At the elbow is like an area that crossovers to different.
Oh, okay.
Do you know the answer to that?
What is it?
Who does the elbow?
Like a cortisone shot.
Tucker do
Like a cortisone shot or
Yeah.
might be non-op sports? I don't
in
think,
the elbow?
yeah, I think. I
I
think
think
the
it's hand,
hands-
or I think it's hand or, I thought it was
Oh,
hand
really?
or shoulder.
Like you said, it's like right in
Yeah,
the,
In the
yeah.
middle.
you're right in the middle.
Yeah, so you call and
I
talk
can give you my
that,
knee shots and leave it.
the VIP, that VIP number.
Oh.
You call that and they can definitely guide you better.
Okay.
Sorry about that. That was a hard question.
And we didn't start it.
I know.
You really had your knee done.
Both.
You did it both.
It's for him.
Oh,
I
okay.
want him to see what it's all about. Oh, yeah, I had both of them done.
How long ago?
This one was first, I don't know, maybe it's 4 years. And then I had, a couple years later, I had this one done. I didn't have them both done together. But they do it different now.
Mhm.
The recovery is a lot easier.
Good. That's why I'm waiting for it to be easier.
I think this is as easy as they're gonna get.
How many people are on?
Because they don't cut the tendon anymore.
For what, Lunsky? I don't know, but if you just go on our YouTube page, I could probably answer you.
You have trouble, you're having trouble, right?
One knee.
Just one.
What is your
Ultimately, if you have trouble
Status.
with one,
When you have, eventually with the other.
it's
Perfect, a small little crowd is perfect. This is perfect. Can we start, Rick?
Yes, please.
So, good evening. My name is Fabio Orozco. I know some of you already. I'm a hip and knee specialist at the Rothman Institute. And good morning for people who are over there in the web. It is a pleasure for me to be here. Thank you for coming. I would like to thank Casey and Rick for helping us to put all the stuff that we do together with the community. And this is a very simple and short talk about knees. I am the one of the joint specialists, and what I do is basically hip and knee replacements. So what I would like to talk to you today is more about knee arthritis, more than anything else. Not too much about the little meniscus and little things like that, which we also do, but it's not my expertise. I do more the taking care of the flat tire and the flat rim more than anything else. In terms of arthritis of the knee, in this because it's the topic of today, knee arthritis is very, very common, and the most common reason for knee arthritis is basically wear and tear. And everybody, just like a tire, has different pattern of wear and tear, and we call it osteoarthritis or degenerative joint disease. And it's different than rheumatoid arthritis or other type of inflammatory arthritis, which are also common, relatively speaking, but not as common as the regular wear and tear or osteoarthritis. Many times people confuse osteoarthritis with osteoporosis. And osteoporosis is just that your bone quality is not good. Osteoarthritis is more just the joint space, the space in between the joints. Just is the cushion part of your joint is not working properly. So, hello. So, in terms of what to do when you have knee pain, usually when you have osteoarthritis, you're going to have a progression of symptoms that usually starts with mild pain and eventually goes to pain that is more significant and more severe. And your activities of daily living usually start getting a little bit affected occasionally to the point that becomes more and more marked. In terms of the conservative treatment for knee arthritis, it's always important, no matter what, hip or knee, to try simple things first. And the simple things that we can try to control the discomfort for knee arthritis are losing weight. It's very important to try to keep a weight that is adequate for you. And it doesn't have to be, 100 pounds, but any type of, any weight that you can take from your knees becomes significant. Because when you go, for instance, up and down stairs, you put about 3 to 5 times your body weight. So if you lose 5 pounds, you're probably taking 20 pounds of weight from your knees. So it is significant and exponential. Anti-inflammatories in general, the regular over-the-counter anti-inflammatories work very similar to the ones that you had to pay more and you have to get a prescription. So regular ibuprofen, Tylenol, acetaminophen, things like that usually work similarly. We used to recommend a lot supplements like glucosamine and chondroitin, but the evidence is at best 50-50. When you look at the articles, 50% of the articles say that it may work, and another 50 says that it doesn't do anything. So, if you can buy one and get two in the pharmacy, maybe a good time. Otherwise, it's probably not a good idea to do it. But keeping a good, a good diet, keeping your weight where it's supposed to be, and anti-inflammatories are the basic, simple things that you can do. Other things that we can do to try to change the discomfort is as simple as modifying your activities. And if up and down stairs is the only thing that's bothering you, try to avoid that as much as you can. And then the next step is to start getting injections. And injections can be helpful. And one of the first line of treatments when you guys come to see us, after we do an x-ray and we do a physical exam, injections can be beneficial. And there is roughly two types of injections. Injections of cortisone, and cortisone is basically an anti-inflammatory, similar to Motrin, similar to ibuprofen, but it has a different path. It works in a different path of the inflammation process in your body, and you can do it locally in the knee. So it helps to decrease locally the inflammation. It can help to control the pain, and it's something that we can do, 3-4 times a year. There are other injections that are what people call gel injections. The term is a viscose supplementation. And those injections are basically changing the oil for the end to the engine. What you do is try to lubricate the knee and decrease friction. If you decrease friction, that should create a better ecosystem in that knee and decrease the pain. So those injections are worth it to try when you have discomfort in your knee. They usually work better if your arthritis is mild or moderate. So if the tire is a little bit flat or has a small hole, you can patch the tire, you can put some air. But once the arthritis is severe and you have a flat tire and a flat rim, those injections are unlikely to work, and especially to work for a long time. But nevertheless, something at least is worth it to discuss, and in most cases is worth it to try before getting to the next step, which will be surgery. And once we get to the step of surgery, if you are having bone-on-bone arthritis, there is no role for arthroscopic surgery in that case. And a simple way to look at that problem is that if you are bone on bone, so if the ceiling is the femur, the upper bone, and the floor is the tibia, the lower bone, and we are the cushion, we are the cartilage and the meniscus. In order for those two structures to touch each other, to be bone on bone, they have to get rid of us. So if you have an MRI and your knee is bone on bone, the MRI is going to say that the meniscus is torn. Lateral meniscal tear, medial meniscal tear. The reality is taking care of the tear will not change the fact that the pain is coming from the bone on bone. So you have to be careful, because if you just have an MRI and don't have an X-ray, you may miss the real problem, which is that the ceiling and the floor are collapsed and they are touching each other, and fixing the chair is not going to change the problem of the room. So you got to be careful with that. And in general, arthroscopic surgery is not one of the proper treatments for arthritis. So what really works in terms of surgery is knee replacements. And there are partial and there are totals, and depends on where you are. Most patients, by the time they make it to having bone-on-bone arthritis, more than one compartment is affected, and in general, most people will require at that point a knee replacement, a full knee replacement. Knee replacement, which is what I do, work really well, and we do surgery that is less invasive than what we used to do years ago. We in general do not like the term minimally invasive, because there is nothing minimally invasive about an orthopedic surgery that requires cutting some pieces of bone and using instruments that are power instruments. So the term minimally invasive, in my opinion, is more commercial than anything else. But I do believe that we do surgery less invasive, and we try to be very careful with the way that we manipulate the tissues. How much do we cut? What do we cut? What do we preserve? And we preserve a big part of your own knee, even while we're doing a knee replacement. And for the most part, what we do is we cap the ends of the bone. So we don't take inches or centimeters, we take millimeters of your knee, and we almost resurface the knee more than anything else. We also keep the ligaments on the inside and outside. But what happens with arthritis is, just like a tire, it has a tendency to go in one or another direction. It's unlikely to wear exactly straight. So as the knee goes into one direction, you can develop a bow leg, or if it goes in the other direction, you become knock knee. So those deformities are important because your knee is unstable. The ligaments are not well balanced. So one of the things that we do during a knee replacement is balance those ligaments and make proper cuts so your knee is straight again. In the ideal world, you want to put that knee as straight as you can with whatever your alignment is. Just like a tire, you want to have a new tire, but you also want that tire balanced to the car. You want to have the knee balanced to your knee, to your body, to your leg. So in that way, has a potential to not only feel the way it's supposed to feel, as natural as possible, but also last as long as possible. Surgery is done under spinal anesthesia, which is safer than general anesthesia. And the surgical procedure itself is less than 1 hour. Most patients stay in the hospital one night and go home after that. So there is no a long hospital stay. And we, as a Rothman Institute, and me personally, believe that the shorter hospital stays for patients, the better. Less infections, less depression, less problems. Most people go home the next day, and the recovery time is no longer many months. Recovery time is more weeks. So 4 weeks or so is what it takes to recover from a knee replacement. And everybody's different. Some people can recover a little bit faster. Some people can recover a little bit later. Depends on how compromised they have been. But those days of 6 months of recovery or things like that are very uncommon nowadays. And one common question that patients ask is, am I too young or too old to have a knee replacement? And before we open these two questions, I tell you that my belief is that you are not too young nor too old to have a hip or a knee replacement. It's all about quality of life. And if you feel that this is affecting your quality of life, it's the right time to get it fixed. If you don't feel that it's affecting your quality of life, it's not the right time to get it fixed. And it has nothing to do with how old or how young you are. Obviously, the older you are, the more careful we have to be with all the medical things around you. And we need to make sure that everything is done in the best, proper, safe way to minimize any type of medical complications. So saying that, I would like to open, I want this to be as informal and as informative as possible. So we can talk for the next half an hour, whatever questions you have, more than happy to answer.
How long can you continue to get cortisone shots?
So cortisone, while cortisone is a very good anti-inflammatory, just like anything in life, there is also adverse effects. So in general, and this is not a complete 100% rule, but in general, you don't want to have more than 3-4 injections a year. What happens is, as time progresses, there is evidence that if you use too much cortisone in your knee, it actually becomes detrimental for the quality of your tissues. So that's one part. The other part is that there will be a point where the injections do not work as long. So if I give an injection and it lasts for 3 months, 6 months, that's pretty good. But if I give an injection and it lasts for, by the time you make it to a parking lot, the injection is gone, then it makes no sense to keep getting it, So, but that's a simple rule. You don't want to have too many of them,
Doesn't it
I'm sure.
Finish.
No, doesn't it clean your bones also?
Yeah, it can affect your bones as well. Yeah, the quality of your bones. Yeah.
We both have knee problems. Sue had her left knee her right knee replaced with Dr. Rothman many years ago. But now her left knee and my right knee are not good. I am fearful of an operation because I had a hip replaced in May of 2010. The surgeon was not a Rothman Institute. I won't mention his name. But what he did was he stretched the femoral nerve, it was the left side. So I had no quads and I constantly fell. And I had 14 or 16 weeks of therapy. It was not good. So my history of orthopedic surgery has not been favorable pending that. So I kind of have held off on doing anything.
Is the needle bothering you on the same side of on the left side or on the right side?
Well, the right knee is the knee.
And the left side
The
was the
left
hip.
side
you
was
know?
the hip. Yeah. So right now, I'm feeling, the way I'm walking, I'm probably having some discomfort. Maybe I have osteoporosis, which I probably do. So that's why I held up. So we tried the cortisone, and we also tried the Synvis or something.
Yeah, gel.
Yeah. In Sue's case, it made it worse. She was worse with that. Mine wasn't worse. So right now, we're just toying with some other ideas. But
I think that nobody wakes up and says, I really just want an operation right now. I just want to have surgery done. But I think it just, like anything in life, there is a point, and you went through that at one point with your hip, where you say, you know what, this is too much. This is affecting my quality of life, and it's just time to do it. It's normal to have fears, and I think all of us have fears around a surgical procedure, and the fears come from many, many, many things. They come from experiencing from other people. They come from our own experiences. They come from not knowing exactly what to expect. So working on expectations is very important. And they also come from not having enough trust. And I think that the simplest way to approach a problem is this affecting your quality of life or not? And if the answer is yes, well, you're probably going to have to think about getting this fixed. So the next step is, where do I have a fix? Who do I have take care of me? And what are my concerns? So it's important in your particular case, because you happen to have something that is uncommon, to discuss what are the possibilities, as much as you can tell, of having a nerve injury after a knee replacement. And I can tell you that it's very uncommon to have a problem with your knee, a nerve problem with your knee after a knee replacement, even less common after a hip replacement. So your fear is very well founded, but at the same time, you gotta be careful, because fear should not be able to stop you from having quality of life. So you know when is the right time, and you know when you say, you know what, it's time to get this done, and these are my expectations, these are my concerns. Nothing is 100%. What we do is not 100%, and even in the best possible hands. I tell you, I only do this, and I do thousands of hip and knee replacements, but as much as you want to help everybody, there are instances where you just cannot.
I appreciate
And there are so many
honesty.
things you can't control. But I tell you, you will know when is the right time, and your concerns are very well founded, but you still can do very well. One of the things that you don't want to get to a point is where your quality of life and your activity level is so low, because it's hard to bump up again to get back where you want to be. So, the good thing for the two of you is you have problems with your left knee, you have problems with your right knee. You just have to just pick what side to go and just walk together, Help you'll be each other's cane.
The other situation is that sometimes, and not you, I mean, just the reports that it's 4 weeks, 6 weeks, 8 weeks, and you're going to feel good and everything else. That may be true, but it wasn't true with me, and it hasn't been true with other people I've spoken to. They say it's 4 to 6 weeks.
The only way that you can compare yourself and how potentially you'll do is if you inform yourself and you talk to patients. We believe, and as much marketing as we have, and there's a lot of stuff in the internet, and there's articles and things that we write, but we believe in the simple mouth-to-mouth and how patients tell other patients. And if you have somebody who has similar circumstances than you, similar age, motivated person, good looking, who has a similar problem and goes to a similar doctor or the same doctor, you can compare a little bit more apples to apples. It's just difficult to compare yourself with people. You know, everybody has different expectations, different motivations, different doctors. So those things are very, again, you are right. But I can tell you that the recovery time after knee replacement is very different than what it was 10 years ago. And we drive for rapid recovery. See, one of the things that we have changed in the last 10 years, just to put a date, is it's not too much making small incisions. It's not too much, do you cut the tendon or do you cut the muscle? It's not too much that the materials are better, which is important for long term. And they are better and they can last longer, and that's important. But I think that we finally understood how to treat patients and what is about the patient that make him have a long recovery or a bad experience. And during that process, just to make it simple without going too much in detail, the three main reasons why patients don't have a good experience in the hospital, and everything starts right there, are pain, nausea and vomit, and hypovolemia. So pain, we used to be more reactive than proactive. We waited for the patient to have pain 8/10 to finally give them something for pain. And we use narcotics. And narcotics do take the pain away, but have so many adverse effects after that. So now we are proactive and we start anti-inflammatories and pain medications before surgery. So by the time you had the surgery done and you are getting to PACU on your floor, you are comfortable. And if your pain is 2/10, you can control that easier than if it's already an 8/10. So that right there starts things much better. Nausea and vomit. I mean, you have general anesthesia. We give you narcotics. How can you don't have nausea or vomit and you haven't eaten for 24 hours? So we don't do that any longer. We actually let our patients not eat, but drink the morning of surgery. And that way your stomach and your system, if you like coffee, you can have your coffee in the morning before surgery. And that's better for patients, quality of care. We actually start giving you anti-nausea medications before we give you anything else. And we don't do general anesthesia, so we don't have to give you this massive amount of medications that have that effect. We also don't use IV narcotics, which also have that adverse effect. And then the management of fluids. While you guys during surgery don't bleed that much any longer, your fluids, as one of the reactions of your own body when it's going through a surgical intervention, is you start shifting a lot of the fluids. And no matter what, even if you do surgery under tourniquet, you do have at least a shift of your fluids. You lose some blood, your fluids change, and that causes patients to have hypotension. You're also being laying down in bed for a long time, laying down on your table during surgery and things like that. So when you're trying to get out of bed, you can have orthostatic hypotension. So managing fluids before that happens is also important. So controlling pain properly, controlling nausea and vomit, and controlling fluids, just that helps the patients to start a faster recovery or a rapid recovery or a fast track program, however you want to call it. The point is that gives you a good platform to start recovering better. And the other part is people used to be in bed for 24 hours. We didn't get them out of bed. They have Foley catheters. They have all these IVs, epidurals. We make you wireless from the beginning. So no Foley catheters, no epidurals, no IVs. And that helps patients to start getting out of bed and have a different experience. So that is what it is. And I think it's a little bit less relevant if it takes you 2 weeks to recover or 6 weeks to recover. The important part is from the beginning, depending on how bad you were, you're going to start moving. You're going to start walking. Most likely not even a walker, just a cane. So you get into a system that helps you to recover faster. And if it takes you 6 weeks, or if it takes you 8 weeks, everybody's different. You know, I run pretty fast. Some people run faster than me, and some people run slower than me. And that's the way life is.
Is it common after a knee surgery to go home instead of going into like a back rack?
So 90% of my patients or more go home the next day after surgery.
Oh, geez.
Very, very, very few go to rehab. So the way that I feel about this, and this is personally Dr. Orozco, the way I feel about this, is that if you come home with a flat tire and a flat rim, why you would not go home with a new tire and a new rim? At the very least, in your early recovery, you'll be the same or better than what you were when you came. And in general, home is a better place. You know all your bugs at home, and the bugs know you, so less infections. And it's a better place for sleeping disturbances, for depression. It's better to be home. It's your own environment. So I will focus more on getting a support at home before surgery and for the first week or two, than going to a rehab place where people would love to do the best they can for you, but there's many patients. And if you go to rehab, for the most part, you already have some issues, medical issues. So in general, I recommend home.
But you still
Saying
go to
that,
outpatient rehab?
yeah, saying that there are patients who are, because of their circumstances, personal, social, medical, they are better going to a rehab place. But the vast majority of patients, especially the patients that come from home, can go home.
And then they go for outpatient.
And then
rehab.
you can do outpatient therapy, which actually is a very good motivation. You know, we just did a study that we published in terms of when it's safe to go back to drive. And we showed that in 14 days, so 2 weeks, your recovery time is your reaction time, not recovery time. Your reaction time is, in the vast majority of patients, is back to baseline at 2 weeks. So that's a motivation for patients. The first 2 weeks, probably not a good idea to drive, but after that, if you're not taking any pain medications and your reaction time is back, you could potentially actually drive to a facility and do therapy as an outpatient. So all those things, you know, many times in therapy, we used to focus on walking backwards and walking sideways and doing things like that. And we forget that for the most part, we need to walk forward. We need to go up and down stairs. We need to stand from a chair. We need to get inside, outside the car, simple things. So why we just want to start with the simple things in life that most patients start missing as the disease progresses, and then we can go to walking backwards, jumping, whatever we can do. But it's important to have expectations and goals that are simple. And the best exercise after a hip or a knee is go and walk. You know, just go and walk, go to dinner, have a good time, go to the boardwalk, start moving.
If you don't do epidural, what anesthesia do you?
Spinal. So in terms of anesthesia, we don't do general. You cannot have a knee replacement done under local. It's not enough. It's not enough. So the in-between that works really well is what we call regional anesthesia. And in terms of regional, you can have an epidural or you can have a spinal. We do spinals because epidurals work, but they last long. And you don't want, you stay numb for too long. Also, the medications they give you are more, so you have more nausea, more vomit, and things like that. And the motor part, being able to move your knee, move your legs, also takes a longer time to recover. The last part, which is the part that I really don't like, is that you lose control of your urine with an epidural. So you have to have a Foley catheter. With the spinal, because it's a much shorter acting anesthesia, you have the same benefits of any regional anesthesia, so same benefits that you have from epidural, but you don't need a Foley catheter. It doesn't last for a long time, and it doesn't affect the motor part for longer than whatever it is, 4 hours, 6 hours. You know, surgery is really less than 1 hour, so you don't need the spinal to last that long. You just need it to last during that period of time. So that's why we don't do epidurals.
How long have they not done epidurals?
Everybody's a little bit different. I haven't done epidurals for many, many, many years, but everybody has a little bit of their own kind of like fine tuning of how they do things. But I haven't done epidurals in many years.
How many is many?
Many, 5
Okay.
or more.
Yeah. Well, I had both knees
Yeah.
done, so I thought they gave me another door, but maybe you're right.
Yeah. Sure.
Where do you operate?
I do surgeries at Mainland, Atlantic Care Medical Center in Pomona, Mainland.
What's it called?
Mainland, Atlantic Care.
By the airport.
Is not too far from there. It's by Stockton College.
It's not.
Galloway.
Yeah.
Sure.
I'm a local high school football coach forever, retired. A long time ago, the first thing they did with the kids was try to drain the knee. And then they had the kids wear those braces all the time. I haven't heard you mention either one of those. Are they
Yeah.
old-fashioned now, or-
So we don't in general do draining of the knees. What happens is when you have swelling on your knee and your knee gets really, really big, if there is any tension in the skin or something that is like an intractable pain, you could potentially take some fluid out. The problem with fluids, as you know, is that they work based on pressures. And the more fluid you take out, the more fluid that will get back to that same cavity. And that's how you get into aspirations. And this patient used to go every week to get his knee aspirated. And so in general, it's not a good idea. It's better to use anti-inflammatories, to use ice, maybe a knee mobilizer if you ever have to, and do an injection of cortisone to decrease the inflammation and let your body little by little decrease that inflammation. That is usually better for mid and long term than taking the fluid out, because it will come back right away.
Well, I just recently, yesterday, had it drained and had cortisone shots. And I go to Rothman, and the past couple of times, he's taken a little bit of fluid out because it's all, but also gives me a cortisone shot.
Okay, that's fine. I won't take it out. But
You wouldn't have taken it out.
Now, if you come home the next day and you have to go up steps, can you go up steps?
Yeah.
Just
Yeah.
like I do now.
Yeah.
Right, bad one down, good one up.
Yes, you can do steps from the beginning. As a matter of fact, one of the things that we do before we discharge patients is we look at how is your environment, and we simulate steps. We simulate getting inside, outside the shower, sitting, standing, and stuff like that. So that's part of, we will not, and when I say most patients go home in one day, everybody's a little different. And we will never send you home unsafe or uncomfortable. But I tell you, if you get into your system, if you prepare yourself and you have the expectations of going home the next day, and you are ready and you have some help, you can do just as good, better than if you go to a rehab facility. Home is a definitely better place.
Even if you have a couple steps to climb?
Even if you have steps, absolutely. Yeah, we don't give you having the steps at home is not an indication to go to rehab.
Okay. You said you could drink coffee in the morning of the operation.
Yes.
That's uncomfortable.
You wouldn't like it. Oh, it's fine.
The steps aren't the problem. I don't know why everybody's worried about the steps. The steps aren't the problem. I've had it done. I'm ready to do another one. And there's nothing like it to walk around with pain. It's ridiculous. Because once you get over everything, you're a new person. You don't even remember you had any of it. So, I don't agree with everything that you just said.
It's okay.
But don't go home the next day and don't go to a rehab. And it depends on how much help you have at home. If you live by yourself, you absolutely have to go to a rehab.
And again, I think that I agree with you. Well, you don't agree with me. I agree with you. And yes, I said maybe you guys didn't hear what I said, but I think that there's always going to be a place for some patients to go to rehab based on their personal situation, their social environment, and their health. It's just not for everybody. And but as a plan A, home in general is a very good plan A. You can always go to plan B. But if you have no support at home, I think that you definitely should consider going to rehab or get some support if that's something that is feasible. But I do appreciate what you're saying about the relief of pain that you have, and that is the reason what I do what I do. I care about my patients like my family, and that for me is not aligned as the way that I live, as the way that I work, and that is the part that rewards me the most, is being able to change people's quality of life. I don't save that many lives, but I change a lot of people's quality of life, and I think that is very, very rewarding, because at the end of the day, it's not how many years we live, but how good years we live. That's what matters.
I was at Rothman today on my third, I think it's, series of 4 shots that I get every 6 months. I had them last fall, and they were quite effective. I spent winter in Florida where I got this thing. And I just put this on to remind me, because I'm not in pain all the time, only if I turn the wrong way. If I say, oh, or I move myself suddenly one way or the other. Now, the question for you is, I'm taking ibuprofen, which seems to be helpful. I have arthritis in my neck also, and I guess other places like that finger, but that doesn't bother me. Is that okay to take every single day, every morning?
Everybody is different, and we all have different kidneys and different livers. Ibuprofen is a very good anti-inflammatory, and it is safe to take. The question is, how long can you take ibuprofen? So anything in excess is not good. So if you do take ibuprofen every single day, and you have to take it very often, you take it only once a day, it's much better than if you take it many, every 8 hours or things like that. So you just have to be careful. If you are taking things like that, it would be a good idea to talk to your family doctor, because it may not be a bad idea to have a checkup periodically of your kidneys function, your liver function. Make sure that you are not doing any harm to yourself. One of the things that you can do is alternate different medications to try to decrease the possibility of adverse effects.
I was taking acetaminophen, but then I was told that ibuprofen
That's,
would be better.
yeah. So ibuprofen works really well. It's just like anything. If you take it every day, you just have to be careful.
About Mobic.
Same thing. Is that any of those anti-inflammatories, they work in a similar pathway, and they all have different type of adverse effects. I like anti-inflammatories like Mobic or Celebrex because you in general only have to take it once a day. So, but at the same time, if you take it every day for a year, 2, 3, 4, 5, it's just a lot.
How about every other day?
Again,
do it every
better than
other day.
every day.
You know what I mean?
Yeah.
We need something.
I agree.
We have a question online.
Sure.
What is the youngest patient you've ever done a joint replacement on?
So the youngest patient that I have done a knee or a hip replacement, I'll say 15 years old. They are younger patients who are candidates for a hip or a knee replacement. That is, the diagnosis are a little bit different than the wear and tear from osteoarthritis, but there are patients who have congenital dysplasia, juvenile rheumatoid arthritis. There is a condition called sleep capital femoral epiphysis, where the growth plate falls. There are trauma, moral-vehicle accidents, and things like that. So, and also something called avascular necrosis, where the blood supply to the femoral head gets compromised. So I have done hip and knee replacement patients who are younger than 20 years old. And that is a patient that you can really change quality of life, because these people have not been able to experience what most of us already have been able to do, and they haven't had kids. They have other different expectations. They are very active. They want to go back to sports. Even if they're not active in their body, they're active in their mind. And so their mind thinks they can do more than what they can. So it's a very special a group of people to work with, very rewarding as well. And one of the good things about 2015 for this type of patients is that the technology that we have, the materials that we have, can last for a long time. And while nothing lasts forever, implants hip and knee implants can last nowadays for decades. So it's not something that's going to last for the 5 years or 6 years, but it can last for decades. And that's one of the very, very good advantages, and one of the reasons why we can do hip and knee replacements on people who are younger. So that's a very good question.
There's a different kind of hardware you use, different options.
So yes, there are different options that we can use. I try to give the best to everybody, and but yes, patients who last, who have expectations that to last longer than others, definitely the materials that we have to use gotta be the best we have. I use the best materials we have for everybody. But in terms of fixation, for instance, we have nowadays cementless knees that don't require glue to be attached to the bone. And that is a very good alternative for people who are younger. You have a very good bone quality, and you have the expectation that could potentially help this knee to last even longer. There are ceramic structures that we can also use, especially for the hip, that can have a longevity that is way better than the traditional metal and polyethylene as well. So yes, the quality of the materials is something that definitely play a role, and it becomes even more important if your expectations are to be here for 50 years and not for 20.
As my husband said, I had my left knee done by Dr. Rothman. He happened to be in the office here, and he took a look at it and he says, "I'm going to do you." And then I made my decision within days. He almost died when I said, "Okay." And I had excellent results. He was great.
That's great.
And as he is. And I got up, they made me walk. I was at rehab within a couple of days after I got home, and the rehab guy had me, he was hanging on to me, and he says, "You can do it, you can do it." I said, I can't. He walked away, and I walked. And that was within days after my surgery. However, 14 months ago, I went to Dr. Austin and had my right shoulder done. And that is a whole different situation. Nice.
That's what we're talking about, knees only here.
Yeah. Get away from that.
Replacement or just
Replacement.
And
Shoulder.
that's a different ballgame.
Problem
I
is,
still have to.
No. Dr. Cuff in Florida.
Oh, I couldn't sleep. I couldn't find.
Rotator cuff or something else?
the rotator cuff is okay.
So we have a question from a runner online. He says, at what age do folks need to start worrying about the shortening of muscles and tendons, and does it have any effect on knee arthritis? Can it be caused by knee arthritis?
So what happens is, as we age, we lose some of the cartilage everywhere. A spine is one of the reasons why people start little by little, moving forward slightly. Same thing happened to your hips, to your knees. Everybody has a different age because we all have a different DNA program. But when that happens, your ligaments start getting under different forces. And there is a ligament, especially if your knee goes into varus or valgus, that one of the ligaments will be shrink and the other one will be in too much tension. So there is not really an age. I think everybody is different, but one of the things that we know is that if your grandmother, your mother, the dog, everybody has arthritis, very likely you will develop arthritis. Then if nobody in the family has arthritis, you have already a good DNA bank there. Genetics have definitely something to do with it.
Yeah, for sure. Yes.
A question, we were suggested by the dietitian that I see periodically about a drug, I don't remember the name of it, but we had it filled. It's 840 milligrams of ibuprofen.
Mhm.
It's a large pill. It also has a coating in there that you can take more than one a day. So we started with that, and and you had it also. Okay. Okay, we won't do it.
Don't fight, she has it, she's your right side.
Well,
Yeah.
we won't
I have a
go into
very
it.
good
I'm not
right.
going there. Half the bottle's going though. In any event, it works, it really does.
Yeah.
But we suggested it to our doctor,
Mhm.
and he said, I don't want you to take this drug.
He probably knows you better because he knows your function and all the stuff. The advantage of having one pill is basically the same thing. You can take 4 pills or 200 milligrams, or you can take 1 pill of 800.
Well,
And then you can have the 30 cover or not. So
You can take more than one, that's the thing. It said you can take more than 800 a day.
yeah, you could potentially do that. But again, your doctor knows you better.
Well, he's not taking
And
it.
based
Yeah.
on your function,
Yeah.
how your kidney, your
Yeah.
liver, and the stuff like that works, you probably know what's best for you. In general, it's good to take 1 pill and instead. That's perfectly fine too. A leaf works really well as well.
Does work.
Absolutely. Sure.
What is the substance that's used in these gel injections?
So the gel injections, they have different names, but basically what they are is a material that is viscous. There's gel, basically, and the content is called hyaluronic acid. Hyaluronic acid happens to be one of the main components of a normal joint fluid. And as we develop arthritis, not only the quality, but the quantity of hyaluronic acid is not there. So basically it works because it has that component that is a good component, healthy for the knee. And then the quality is gel, which is basically what oil does to the engine, decreases friction. So that's basically, and they have different names, but they're very, very similar, basically.
Any side effects?
Anything that you do and you have in life has side effects. You know, if you read the small paper, the small little print, when you're gonna buy a car, when you're gonna get married, or you're gonna take a pill, you will never do none of those things. So anything has adverse effects. They're very little, very uncommon, but yes.
We have another one online. It says, do you think it is better for the body to exercise consistently with arthritis, or to take breaks away from it and let the body kind of heal and slow down?
So that's a great question. I think everybody's different. Everybody knows your own body. Everybody's body, just like car. Every car works differently, and there are some automatic, some manual. Some like to work with high reps, and some like to just work with low reps. Everybody's a little bit different, but in general, I like the idea that if you have been diagnosed with osteoarthritis, it's a good idea to alternate exercises. If you have significant arthritis, running every day is not the best exercise for you because you'll be having that impact into your joints and you don't have that much cushion. But for many of us, running is part of life. So I don't recommend stop running, but I think you can alternate. And you can run, you can bike, you can do elliptical, you can lift weights, you can kind of do a little bit of all of the things that make you happy. But that would be my general recommendation, to alternate exercises. I don't like the idea of not doing anything and one weekend go crazy and then don't do anything and then during the weekend go crazy. That usually is not good, not just for your joints, but not good for your heart as well. So I think just mixing a little bit of cardio with a little bit of what you like to do every day, having a good balance probably will be the best way to approach, especially when you have osteoarthritis. Any other questions? Good. Well, I thank you so much. I hope I keep it very short and nice. Appreciate you guys coming, and thank you so much for being there online. Appreciate it. Thank you.